Thank you so much. I'm quite excited about the opportunity to provide an update on behalf of Australian Genomics and how we're using GA4GH standards across the board in day-to-day operations. Let's see, this works. Okay, there's a slide missing, but that's okay. For those of you who don't know, Australian Genomics was funded back in 2016 by a grant from the National Health Medical Research Council in Australia to address challenges of genomics in healthcare. It is led by Catherine North, who also happens to chair the session, so that is quite convenient. The grant had and still has a number of aims, and I've highlighted a few relevant to the talk here. The key aim to me is the mission to develop evidence for the integration of genomics into healthcare. And Australian Genomics does this through a number of different focus areas, such as building national expertise, but also improving the legal and ethical frameworks that underpin this initiative, and which are absolutely key to improve acceptance of medical genomics. Tied to that is an effort to safely store and responsibly disseminate genomic information in agreement with patients' wishes. My talk will mostly focus on the systems and the methods and the informatics for the rest of this session. But I'd just like to point out that none of those methods and implementations really matter unless those key governance and ethical frameworks are in place. Australian Genomics itself is organized actually quite similar to the Global Alliance, in that we have a number of driver projects, in this case 21 clinical flagship studies, that are then underpinned by a number of different infrastructure programs, for example, to build a diagnostic and research network, to improve our ability to store and federate data, policy development, and workforce development and education. In phase one, which is just about completing, Australian Genomics had over 100 partners and recruited from more than 30 sites. Let's see if that's working. There we go. And it is truly a national project. Participating sites are in all states and territories. We ended up with a federated model with regards to patient recruitment, sequencing, and primary analysis. But then after some initial concerns, we were able to centralize the read level and variant level data in multiple warehouses in one place. I realized that it's not an option for all initiatives. It probably wasn't absolutely necessary for us, but it did simplify the logistics, the setup and maintenance of those systems. Coming back to the aims, I did skip one previously, and that was an earlier realization that Australia probably should not do all of this on our own. Certainly not when other large-scale projects and national initiatives have already paved part of the way. And the key mission here was not just to learn from other initiatives, but to contribute back, to engage with those initiatives, and to share knowledge. And I think that explains to at least some extent our participation in the Global Alliance. Australian Genomics is a driver project. It contributes to standards, works with other driver projects to share this information, and participates in different work streams. I would say that our participation in work streams is probably a little bit uneven. We certainly had an early emphasis on the foundational work streams, working on security models and scenarios, developing a national consent model, ethical guidelines. But I think by now we are pretty much active in all technical work streams as well. And the participation ranges from active contribution to standards development to just more of a monitoring status, where we are implementing already developed standards. Cloud is a good example of this, where we take existing standards and deploy them here, but we don't necessarily participate in the actual development. This was the part where I was going to pitch the Genomics and Health Implementation Forum, but Catherine already gave a very, very good overview of this. I will say it was a very interesting, exciting meeting last week around this. The 200 participants really surprised me. I like the informal approach of sharing the information through SOPs, guidelines, and reference implementations, but also share what doesn't work for certain organizations. So I think it's a very, very valuable resource. So for the rest of the talk, I will be focusing on some of those implementations. Workforce and education are absolutely key, but a little bit out of scope for this. I did already mention the importance of the GA4GH foundational work streams, policy and ethics, and Australian Genomics has been participating in those, developing security, consent policies, and supporting initiatives like Your DNA, Your Say, and International Participant Survey. That work is certainly not done yet. There are more policies being developed, for example, return of results policy. And I do encourage everyone to get involved in those. For the rest of the talk, I'll be mostly focusing on the diagnostic research network and the data implementations. And this immediately then leads to those fun diagrams that try to model how data flows through a system like Australian Genomics. And they tend to be a little bit fractal. The more we zoom in, the more details emerge and the more complicated and convoluted it all gets. So I thought it might be a little bit easier following the GA4GH presentation earlier and following a single sample or a single flagship from patient recruitment to analysis all the way to reuse. And the project I picked for this, we picked for this really, is the Acute genomic flagships that was established in 2018. It has a mission to develop rapid genomic testing for critically unwell babies and children, and is a study co-led by Sunitza Stark from the Murdoch Children's Research Institute. And it really pioneered the national approach to rapid rare disease diagnosis. And the emphasis here is on rapid, with a turnaround time of less than 4 days from sequencing to initial reporting. That required a streamlining of processes all across the board, from the recruitment to the curation, and hopefully soon to reanalysis. So going back to the flow diagram, I'm going to start with the initial part, looking at data capture and how that process was streamlined with speed in mind, and making use of GA4GH standards wherever possible. That all starts with a very simple but efficient electronic test ordering system that captures basic information, but it also immediately tries to capture clinical features, not in free text, but in suitable ontologies, in this case, the human phenotype ontology directly. The information is still stored in a REDCap database behind the scenes, so it doesn't necessarily have the full capabilities of a FHIR server, but it standardized the inputs quite early on. And I'm certainly not the best person to talk you through this. I'm a bioinformatician, not a clinician, but talking to the users, just having this electronic system in place already significantly speeds up the process and reduces the burden on clinicians and data managers. The information being captured isn't limited to phenotypes. It also captures pedigree information for patients early on and stores that information in a structured manner. It is certainly a step up from PDFs or the hand-scribbled example that Catherine showed previously. It is driven by a REDCap plugin, and I've left links to the resource we're using, usually on the slides in the bottom left corner. If you're curious about them, please take a look, and the slides will be available after the talk. For the pedigree information so far, we are using the FHIR family member history specifications, but the plan is to support the new pedigree specification currently being developed by the ClinPheno group. The underlying concept is to represent individuals as nodes in a graph, with the edges then representing the relationships. And it does allow us to model both social and biological relationships between participants. But it's also very easy to reuse as existing standards like FHIR or Pheno packets. If you're interested in contributing, please do reach out. Something else that test captures, okay, I think it just recapture this, hang on, there we go. Lagging on my side, is the ethnicity. There are a number of existing standards that try to capture some electronic health records. We are making use of the human ancestry ontology in REDCap to provide more fine-grained details. That was discussed as a project in a number of different GA4GH work streams. I don't think it has a product owner just yet. And we heard from the talks yesterday how difficult and tricky it can be to capture this information just correctly. So I'd be keen to see development in that area from GA4GH. We store the primary information in REDCap, as I mentioned, but the target is still FHIR. And again, the person you really wanted to be talking to here is Alejandro Metke at CSIRO. The component that handles the transition on our side behind the scenes is called Redmatch. It takes the REDCap forms, it converts or transforms them to FHIR, with them being stored on a separate server for queries. In some cases, that means the information needs to be mapped as part of the transformation process. In other cases, we can take existing information from a REDCap form and populate attributes in a FHIR resource directly. Redmatch is driven by a rules language that requires knowledge of FHIR, but not necessarily programming expertise. Redmatch will be made available as open source. And I don't have a URL just yet because there's still work going on a user interface. The target for this are certainly data curators or data stewards and managers that have an understanding of FHIR, don't want to program themselves, but can implement those rules themselves. So having a good user interface is crucial. And as it becomes available, we'll share this information, how to access the resource. Going back to the test. Okay, I should do this. There we go. Clinicians also selected virtual panels as part of this test. Acute care itself is based on exome sequencing, but the sequencing results can be viewed through a lens of a virtual panel. We're really following the Genomics England model here. The exome is available if the virtual panel doesn't provide sufficient information. But it does limit the initial curation work and reduces the work that curators have to do by focusing on the most likely causal genes. That uses PanelApp behind the scenes. It's a framework developed by Genomics England. And actually didn't realize it's been around for 5 years now. So I stole the birthday slide. At its core, it's an open source crowdsourcing tool to collect, curate, compare a list of genes, and then annotate those genes with evidence for their disease association. And it means ideally down the road, we can harmonize these relationships between large-scale initiatives and between us decide which genes to prioritize for a given disease and testing. It also means a constant editing and reviewing process. Means that those gene lists are not going out of date. Since Genomics England has made PanelApp open source, we have spun up an instance in Australia that has seen very active use, around 240 gene panels, 2,000 updates and edits over the past year, with about 100 reviewers participating. We have monthly coordination sessions with Genomics England to harmonize those gene lists, and we're trying to automate some of those processes yet, again, to reduce the burden. If you're interested, PanelApp is available at GitLab for you to explore. And then finally, electronic consent. Providing, and Tiffany can tell you way more about this, and luckily is handling the Q&A session afterwards, because that's definitely not my area, but providing the public with a clear, consistent information during the consent process is really absolutely key for a patient to make an informed decision about genomic testing. Australian Genomics has worked for probably more than 2 years to develop a national clinical consent standard that can be adopted and has been adopted by Flagship projects. The consent forms also come with additional supporting material, like documents that explain the testing process, explain outcomes or the impact of results, and how we're handling data storage and dissemination. The materials have found really widespread acceptance among clinicians and patients. And because the electronic consent is machine readable, it also allows us to connect this to a dynamic consent system. And I'll talk more about this in a minute. Behind the scene, this consent then gets mapped to GA4GH Data Use Ontology terms, which allows us to map the requirements of someone requesting data from us to the restrictions associated with stored data, and decide whether data can be made available or needs to be kept restricted. That matching algorithm currently is still, for the most part, a manual data access committee, but we really could and should transfer some of those things to an algorithm that creates those mappings automatically. So all of those electronic test stages are meant to be fast and efficient and can be usually completed in like 5 to 10 minutes. And we try to make sure they align to existing GA4GH standards as much as possible. We then hit the clinical sequencing reporting stage, which tends to be very, very different between flagships. It's an exome sequencing panel, whole genome, whole transcriptome, different sequencing protocols. So it's quite difficult to generalize here. For the acute care project, though, I would say it's been really successful. I already mentioned the quick turnaround time of 4 days from sequencing to reporting and a high diagnostic yield. And if you'd like to know more about this specific project, there's a publication JAMA that has details, or just reach out to Zanetza. One area where we are trying to standardize is the exchange of information on clinically interpreted variants. The framework we're using for this is called SHARIANT, and it's meant to standardize the interpretation between participating labs and just improve the curation through sharing evidence, quite similar to what's happening with PanLab. It reduces the risk of error for participating labs. It also means that patients and their family are getting the same results or the same information, regardless of which state or jurisdiction they happen to live in. It took a ton of work onboarding initial labs, work that's been done by Emma Tudini and Mandy Spurtle, and they'll be happy to tell you more about this. SHARIANT was developed in the partnership program, and we're still exploring the right license to make this available to everyone else. Initial adoption has been really good. We tested this, or really Mandy and Emma has tested this with 9 path labs across the country. We're now expanding this to another 30 labs. And one development we're really excited about is ClinVar getting an API for submitting variants to the ClinVar resource, which I think will really streamline the process of getting curated information from SHARIANT into ClinVar itself. Melissa Landrum actually presented on this at the GIF meeting last week. It looks like the API is around the corner, so looking forward to this. Another resource we're looking at is the GA4GH Variant Representation Specification, bit of a mouthful. I think this will also help us streamline the variant information exchange and make sure that the information we're exchanging is consistent. So with data capture and recruitment and sequencing covered, we're now moving to the part of the data flow where we're then storing the data and making it available for reanalysis and research. I'm going to start here with the genomic warehouse or repository that stores our read-level data. It consists of basically 2 warehouses that are operating on a commercial cloud system. One that faces the data submitter and one that faces the data user. And what it allows us to do is run some consistency checks very early on, make sure all the required GA4GH metadata travels with the data and let the user know if there are any concerns. Before you then start some more complicated or computationally intensive tasks, like running checksums on all our data, making sure nothing is corrupted, quality controls are in place. We're thinking of also adding a few more steps at that stage. One is certainly the concept of converting our read data, which currently is in BAM format, to CRAMs. I think most people in the audience will be familiar with CRAM. It certainly would help us to reduce our storage footprint. It also makes the files smaller, means we can share the data more efficiently, and again, saves cost, which is always a good thing. We haven't gone quite that route yet because we feel uncomfortable effectively modifying data after we've taken custody of it and make sure it's not corrupt and all the checksums line up. Also, in some cases, we don't have a complete understanding what exact genome reference was being used to align read information to it. That makes the conversion really, really tricky. So instead, we're working with the sequencing labs upstream to make sure that they submit CRAM data in the first place wherever possible. Another GA4GH standard we are actually actively looking at is GRIP4GH. The comic that the team has put together explains the concept quite nicely, but in a nutshell, GRIP4GH is a wrapper around genomic data, read level or variant level data, that encrypts the sensitive information with one key, stores that key in a small header, and then this header gets encrypted with the personal key of whoever requests the data. That has a number of benefits. First of all, it adds another layer of security and peace of mind to us. Look, even if we ever have the unfortunate situation of a data warehouse breach, the key re-identifiable information is still protected. But it also means we can make this data available on very short notice. We just have to re-encode the header. We can do this live on the wire, and we don't have to duplicate data and constantly decrypt and re-encrypt terabytes of data as we're heading this out. The paper for GRIP4GH is in the process of being submitted. We're now working with a large-scale genomic work stream to work on better tooling and to frameworks to handle GRIP4GH files. From the warehouse, where we have read-level data, information then stores to a variant atlas developed by Warren Kaplan's group at the Garvan Institute. Variant atlas is at its core a web-based interface for exploring and discovering genomic and phenotypic data across our flagships. Users can specify genes or variants of interest and ask questions and identify variants that match or associate with certain clinical features. We had an Australian Genomics data release within Variant Atlas back in August for initial 5 flagships that are mostly complete. And the next 7 flagships will follow in the next month or 2, following on data harmonization. Registration is required, but I do encourage you to take a look at it at variantatlas.org.au. If you just would like to have aggregate information, yes, Australia is on the map of the Beacon network. We do share information on an aggregate level, and that doesn't require any registration. We're still exploring how to best subdivide information across those clinical flagships, but the data is and will be available. I didn't want to miss the opportunity here to also give a quick shout out to a project called SBeacon that's been developed by Dennis Bauer's group, also at CSIRO, which is basically a drop-in replacement for its standard beacon. It does all the same things, but as the name implies, it doesn't require us to run a server 24/7, which really reduces the cost. It also scales really, really beautifully, independent of the size of data sets we throw at it. So if you're curious, there's a link to it in the slide. So in summary, throughout the process, I think we do share quite a bit of information from the clinical side, curation side in PenLab, variants in ClinVar, cohort level or individual detail level in Variant Atlas, up to raw data, raw genomic information, either through the warehouse or eventually by submitting data to the European Genome Phenome Archive. This data shading process is really valuable. We had a number of cases where patients have been diagnosed based on our ability to share data for reuse with other clinicians, can look at this, assess mystery cases, which ultimately certainly helps the patients and their families. If you're curious, here's one publication that describes the process. But this overall process is still quite slow in the sense that we haven't connected all those dots. External clinicians can't really browse the primary data. We have to push it to them on a case-by-case basis where there's interest. That's really not ideal. And there's also really not any good reason for this to be the case. The divide between the clinical sequencing and the reuse sequencing is just based on a couple of technical hurdles. And ideally, we'd like to bring those two domains a little closer together. I do think the components we need for this are already mostly in place or being developed by GA4GH. I already talked about VRS as a variant representation standard, allows us to compare variants more effectively. We are also working with the clinical labs to make sure that they can submit data directly to the warehouse. So as data leaves the bioinformatics pipeline and goes for curation, we can keep a copy already in the repository. The next piece of the puzzle there then is a standard called DRS, or the Data Repository Service, that would allow external users, instead of having to download data from the repository, just embed the information directly from the warehouse, run them, and then pull in the data on demand during their own workflows for harmonization. htsget is something we're also actively working on. It is an endpoint for streaming read or variant level data and just looking at small slices of it. So if a clinician is interested, just let's say looking at BRCA for a number of patients in IGV, that's a way for them to do this without having to download the data, decrypt it, and having to manage terabytes of data for what should be a quick lookup. This does hinge on our ability to connect our electronic consent forms to frameworks that actually can manage this. And DUOS and REMS are 2 examples of this. To use the Broad's data use oversight system, the underlying idea is to have a system that guides and manages data access requests, either through meshing algorithms or to make the job of a data access committee easier and faster. In a perfect world, I would expect data from sequencing labs already to arrive in the warehouse with DUO terms annotated. The users, external researchers, have their profiles set up where they describe in DUO terms what their research interests are. So in real time, we can make data available to them whenever they want to. And then the final piece of this puzzle here really is dynamic consent framework. Australian Genomics has this in place in the form of control. Matilda Haas is the person to reach out to regarding this one if you want to know more. But it allows us to connect our machine-readable electronic consent forms to a dynamic consent backend, and then gives really the study participants ultimate control of what happens with their data. And we can then query their consent guidelines at the time when data is being requested. It's basically provides a two-way communication between the participants and researchers, and it goes back all the way to the original trust that I mentioned that we need to be able to roll out genomics in healthcare. What is holding us back a little bit implementing those final steps is that Australia doesn't have the equivalent of Elixir's AI, a way for us to connect researcher identities to individuals and to something like GA4GH passport. We do have an active collaboration with Biocommons Australia, Zero Childhood Cancers, and a number of other stakeholders to see how this would work in Australia. But it's early days, and we're trying to still understand how to best roll out the service without managing this completely ourselves. Overall, this need for automation that I highlighted, I think is really, really necessary. Yes, Australian Genomics phase 1 is wrapping up, but many of the studies are still ongoing. New studies arriving, like high-profile studies, like a recent one on reproductive genetic carrier screening. And the Australian government has put about $500 million over 10 years into something called the Genomics Health Future Mission to improve testing diagnostic in genomics. So we know this is just the beginning, and any and all improvements we can make to help with automation, scalability, interoperability really will pay off in the near future. Right, I don't think there's any way for me to acknowledge literally hundreds of contributors to Australian Genomics. So I can really just thank everyone who has been contributing over the past years to this massive project. I did highlight a number of contacts for projects that I discussed during this presentation. And I'm glad I'm handing this over now to Tiffany, who knows so much more about this project than I ever will for the Q&A. Thank you so much.